Good afternoon. Okay, good. I know this session is the one after lunch, so I know people are still unwinding after lunch, so we apologize for the late start, but looking forward to getting into our discussions. So without further ado, I'm going to invite our panelists to join me on the podium. I'm going to invite Mr. Samuele Msokwa from UNFPA, or Program Specialist in Population and Development. Please join me. Dr. Ahmed Makwani, Director for Department of Reproductive, Maternal and Child Health, Ministry of Health, Mainland. Dr. Makwani. Lucy Mabada from TAMA, Tanzania Midwives Association. Welcome, Lucy. Mr. Benetios Boniface from Restless Development. I think you're here, Dr. Makwani. And then we have Nectar Richard from Sahara Sparks. Nectar can join us here. And then we'll also hear from the General Secretary of our youth. We have so many partners looking forward to sharing good information with us. As we heard earlier, the topic on this session is follow the data. I'm going to hand over first to Mr. Samuele, who is going to speak to us about population data and investing in sexual and reproductive health and rights. He's going to speak to us a bit about some of the population and data issues that we face in the United Republic of Tanzania and the implications of those population and data issues on sexual and reproductive health and rights. So over to you, Samuele.
Yeah, thank you, Madam Chair, for having me and giving me this opportunity to speak about the use of population data on adolescent and youth sexual reproductive health. I'm wondering whether you can prepare a brief presentation that will guide me to share some of a few information that I think we should use as a starter. Okay, I think while they are loading, I can start to save time. We are all aware that our country conducted the population and the housing census last year in 2022, and also we conducted the Tanzania Demographic and Health Survey and the Malaria Indicator Survey, so we have fresh data from the two major exercises that are covering both demographic and social indicators. So to start with the population, just to remind you, we, as of last year, we were at 61.7 million people, and actually this is a result of an increase of around 16 million from 2012. So for the span of 10 years, a country added about 16 million in the population. There are associated indicators also that were corrected during the census and also some through the Demographic and Health Survey. The first indicator is total fertility rate, and this is a result of what was collected through the Demographic and Health Survey, which is at 4.8. So because we are talking about human being, actually, is 5. And the population growth rate is at 3.2. And out of the population that we collected data for, you are talking about 51% being women and 49% being men. And also among these women who comprise big part of the population, 47.3% of them are in the reproductive age. So bringing also the aspect of having teenage pregnancy at 22%, you find that the momentum for reproduction is high. Even if we were to bring down the total fertility rate to replacement level, that is around 2.1, but we'll still have decades to stabilize so that we have like a declining sort of youth badge because of these associated indicators with the growth rate. So this is as of last year. Now, because we are already there and you are a human being, normally the important aspect is to speak about improving the well-being of these people. Because you don't talk about now this deserve ABC, this do not, but you rather talk about how do you improve the well-being or the life of these people so that at least you can optimize this, for them to get what they deserve to get. So you find that since out of this population also, you are talking about 49% of under 15 and 62% of under 25, it means a lot of investment is needed to these young people and children. And the important sectors to invest are like in health, because they need to be healthy so that they can grow well. In education, for those who have already started going to schools. Why? Because you need to build the capacity in terms of skills and understanding so that they will be productive in the future when they grow up, and they will be part and parcel of the productivity the nation expects in the future. So when you invest and you look at the areas, as UNFPA, normally we concentrate on adolescent and youth sexually productive age to make them achieve the goal of what they anticipate to get when they are adults. So among these young people, you find that these who are actually who do start childbearing at tender age, normally there are difficulties for them to have prosperity in terms of education. So you look at aspects that we need to invest as a country so that they can achieve the highest level of education they would wish, and then they will be productive in terms of economic and social contribution to the national development. There are areas that we need to invest in, especially in terms of population. And you are dealing with population data, so how visible are issues that are related to adolescent and youth in the data and the population spectrum? That is, we need to advocate for their issues to be incorporated in the development frameworks, without which they can be left behind. And the data that were collected, of course, we are doing very well in disaggregating by age and sex and other aspects, but we really need to focus also disaggregating by their performance across different indicators that are related to adolescent and youth. And we also needed to have separate budget lines, because yes, we understand that at council level, there are budget lines that are directed to young people and also to people living with disability, to women, but what amount actually is directed to? So we need to advocate also to increase the budget lines that are going to this segment of the population, because definitely they are the majority. If we are to vote in anything and we are in a rational way, there is no way we can defeat them. And according to the Abuja Declaration, 15% of the total budget needed to be directed to health. So how much do we allocate to that portion, and how much is directed to these young people is of paramount importance for development purposes. And also we need to focus on demand generation, because sexual and reproductive health messages need to be part and parcel of the programs that we are designing, so that if they want to understand, they can easily access this information without hiding. Because sometimes someone may be willing or eager to get this information, but there's no way he or she can get. So we need also to develop such messages that they'll help them to build up capacity in understanding issues that are related to their sexual and reproductive health. And another area is about service delivery, because when you talk about quality services on family planning, especially for young people, you need also to focus on the issues that they are unbiased, and also they have supportive, or they can reach to supportive health providers, because sometimes they would wish to get these services, but the environment are not very conducive for them to be able to access these services. Then they will just keep quiet or pull back instead of getting the services. So when you invest across these areas and there is total commitment, you find that you are building capacity among these young people, and actually you are preparing the human capital that will be entering the production group in the future. And when you have invested and you achieve this, it means now you are preparing the country to reap the demographic dividend, that the benefits that a country can get through investment in young people, specifically in education, health, and nutrition, plus many, many other aspects, such as part and parcel of leadership and good governance, because they are part and parcel of the future leadership in this country. Without which, it means now you'll miss the demographic dividend. And for a country like Tanzania, because we have youth badge, we are talking about the first level. Other countries are talking about the second level demographic dividend. But for us, we talk about the first level, or the first demographic dividend. So I think in a nutshell, I have talked about this. Go back, please. Go back. Yes, there. So for this population, because you go back first to the second slide. Sorry? Okay. Okay, thank you. Yeah, so you go back, you go to them. Okay. The second slide. Second slide. Second slide. There you are. So when you look at the trajectory or the trend of our population, I spoke about 2012 to 2022. But since independence, our country has conducted 6 population and housing census. By 1967, where definitely majority of us were not there, maybe a few were there were about 12.3. As we speak now, actually last year, this year we are talking about 62 plus. So last year we were at 61.7. So an addition of about 44.9 people in the population. But mind you, some other aspects, especially natural resources, are fixed. You're talking about the size of the land, rivers, and all these other aspects are fixed. So consumption is on the rise, but generation of natural resources is not part of our program, because we can't generate natural resources, but we rather create what we can create, like employment and the like. Even using international standards, because some data on that slide are from international sort of aggregate. You find that you are talking about the population of women around 16. That was generated using international comparator when they try to generate figures across countries, 16 million. So in any way, our population is huge, is on the rise, but with so many young people, like I said earlier. Move. Yeah. 5 minutes. Okay, thank you. Move. Yeah, so fertility, actually, this is what I wanted to speak about. Fertility is a determinant of this population growth, because according to census, migration is not that much, and we have stabilized some other indicators, except fertility. Look, from 1999, fertility was at 5.6, and as you speak now, 4.8. So a slight decrease, but not very significant. But another issue is about what age of women are producing more. You find is in between 20 and 29. Because when you go to age fertility specific rate, you find the higher figures are in between 20 and 29. So one wonder, someone at 20, 21, 22, is she not in schools? I don't know whether they have completed. So that is a matter of further study, Dr. Makwan, I think. Yeah. So to conclude, I would like to say this data actually is an opener on what we need to do in our programming. I talked about this data needed to be visible about adolescent and youth reproductive health. We needed to advocate, we needed to create demand, and also we needed to be very sensitive with the services, sites, and type of service providers that we are doing. Otherwise, this slide shows that if we invest, like I mentioned earlier, we'll be achieving the demographic dividend, but without investing, then you will be missing it. And there are challenges associated with missing the demographic dividend because it means many people are unemployed, low capacities in terms of human capital, low product, and then bringing other challenges to the economy and society. Thank you, Madam Chair.
Thank you very much, Mr. Samuel. I think excellent information and good context for us to kick off with the rest of the discussion. I think he spoke very much about the data, and we talk about following the data, and it's telling us many things in terms of the population growth, in terms of the large youthful population, and importance of investing in these young people to achieve the demographic dividend, which is that economic growth that the country can achieve if the right investments are made in our adolescents and young people. And so I'm going to transition now to Dr. Makwane, who within the context of that wonderful data and all the opportunities is going to tell us a bit about the commitments that Tanzania has made with respect to the ICPD, and that's the International Conference on Population and Development, where countries around the world came together to commit to advancing sexual and reproductive health and rights. There was a summit in Nairobi. Tanzania made some commitments around the International Conference on Population and Development. And Dr. Makwane is going to tell us a bit about those commitments, the progress that has been made, and a bit about the roadmap in relation to ICPD 30. Because next year, in 2024, we will be celebrating 30 years of the Conference on Population and Development. Dr. Makwane?
Good afternoon, everyone. My name is Dr. Ahmad Makwan. I'm currently serving as the Director for Reproductive and Child Health from the Ministry of Health, whereby the program for family planning, issues of adolescent, child health, maternal health is seated. When I was invited to come and speak about ICPD and what Tanzania has done, I was saying, what am I going to tell these people? That is the most difficult area that one may dwell, particularly when you have diverse kind of ethics and ethnic groups and issues of religion. Because there is a lot of entanglement between these issues when we are talking about population and development. Tanzania is committed to ICPD, much committed from the ICPD 1994 to 1995, and then post-25 in Nairobi. We were committed to that. And we strongly believe that family planning is one of the areas that helps to improve maternal survival and contribute to productivity of a nation. We are not saying the family planning should stop women bearing children, but we are saying it improved the child survival. And that is possible if the birth, that birth interval is very well maintained, and we are, in the guideline, you will see that we are recommending 2 to 3 years. That is sufficing to make sure women, when they deliver, they recover from the challenges of pregnancy, but they are able to contribute to the economy in a family, in a way to the national development. But also, they improve child survival because they will have that wider breastfeeding so that they can take care of their children. And currently, to show our commitment, you will see that with our partners, we have continuously allocated designated resources in this area for making sure, first of all, we have political commitment. Secondly, there is financing, but also we provide medicines which are critically needed and the other commodities which are critically needed for the family planning. And year by year, you can see the government is increasing its resource allocation in this area. But the other area that is very, very critical is if you want really to achieve the ICPD, which is a commitment of the government again, you need to make sure women in pregnancy and after childbirth, they survive. And children as well, they survive. So you need to have a better care of your newborns who are delivered, a better care for the under fives. And that commitment, you can see how far we have made, how much we have attained in terms of reducing the child mortality. And away from MDG, we achieved our goals, and we continuously, for example, from 2016 to date, the report from THS showed that we have managed to reduce under 5 mortality by almost 33%. That is from 67 deaths per 1,000 live births to 43 deaths per 1,000 live births. That is a reduction by 1/3 of the burden of death from that area. But also, when we come to maternal survival, continuously we have added more resources to make sure we gain our potentials. I'm happy to say that every data that is coming from 2020 to date, irrefutably it shows, whether it is international or local, irrefutably says we have managed to reduce maternal mortality by more than 50% from the number that we had in 2016, 5.6, and the first to echo that one was WHO, which showed that by 2020 we were able to reduce maternal mortality to 238 per 100,000 live births. That is almost more than 50% reduction. And more reports which are coming from the country as well reflect the same. Although we have not made very good progress in newborn reduction of newborn mortality. But in these 2 points, at least, we have made some gain. If you look at the prime area for the family planning, you will see that continuously we are increasing the use of modern contraceptive methods. And now the CPR is almost around 40%. That is 38. By DHS, it is 38. But of course, we do have variations, regional variations in terms of utilization of these services, whereby if you go to the coast, you find coast lines up to Ruvuma, you find women are using more family planning. They are around 50%. And sometimes we as programmers are always saying, we need to be careful. We shouldn't drag into the crisis. So those are the issues. But when you go to the lake zones, you see still they are behind in terms of the uptake. The issue here, I think, which we need to emphasize. We will achieve family planning not just by investing on family planning itself. We should think on issues of education as well. If you educate a woman, it's likely that even the education itself becomes a kind of family planning. Because before she attains a certain level of education, she will unlikely be pregnant, and she will avoid pregnancy. Though we are seeing the data from the youth that adolescents, for example, adolescent pregnancy currently stands at around 22%. That is a small reduction from 27%, which was reported in 2015, and it was 29, almost 30%, which was reported in 2010. So we are reducing the adolescent pregnancy, but still we do have a bigger burden in that area. And I tend to believe the best vaccine in that area is education. If we make sure that those girls from the villages, all of them are enrolled at least to the secondary schools, we are likely that to reduce that burden of early pregnancies or adolescent pregnancies. We have a huge commitment in ICPD, and we echo the 3 zeros. First of all, reduce unmet need for family planning. Secondly, no maternal death. And thirdly, prevent GBV. And all these are being mitigated, are being implemented in the country. Greatly with our partners, we work together to ensure that our women enjoy the services that they expect to get, but also they get protected from gender-based violence. The issue here is how much investment is available, especially when it comes, we have many youths. 65% of the population in Tanzania is below 25 years. 65%, 2/3 of our population. How much potential do we tap from this one? And that's why you can hear we started also another document, NAHIA, National Accelerated Agenda for Adolescents. And you can see from NAHIA, we have, the government has been very pragmatic by starting the vocational trainings. And you can hear from various medias that we advertise young people who are remaining at home, please enroll in this vocational training so that they can get skills. In a way, that is how ICPD wants to have skilled youth. And in our country, I would say we are fortunate because we have more youth than older people. Like in other countries whereby if you are 50, you are called still young. Here, if you are 50, shikamo is plenty. Shikamo is plenty. But in the developed world, if you are 50, they call you young. So how much do we tap? How much, if, for example, they engage in production, how much do we ensure for their markets? Because these are the issues that needs to be answered, practical issues. If my colleagues in Mtwara and Lindi, they grow their cashew nuts. If we ensured that these people, they have the market. If people in Mosh, they grow their coffee, the young people, if we ensured that their coffee is going to fetch market. Otherwise, if we do not ensure that one, that means this cheap source of employment will be undermined, and it will be down. It will be for youth people. They will say, don't invest in agriculture. But they move in the streets in Dar es Salaam, in Dodoma now, with their some pet business on their hands. So those are the issues that we need to explore as a nation to ensure that we attain our commitment towards ICPD. And we really become very practical in terms of that, making sure that we address those issues. Fortunately, we have started, and fortunately, the government is trying as much as possible to give some incentives to some of the youth to start small businesses and so forth. All this is trying to address the issue of ICPD and putting ICPD into practice in the nation. So in short, that's what I would say. Thank you.
Thank you very much, Dr. Makwani. You know, when Dr. Makwani started, he said that I don't know what to say. I wasn't sure what I'm going to say, but he has said so much in terms of the progress that has been made in relation to the ICPD commitments that the government of Tanzania has made. The progress, but still gaps that remain. And I think one of the important pieces that he highlighted is the importance of investing in adolescents and young people. And I think that's a common thread that we've been hearing since the start of the discussion. Those investments in terms of not only health, but education and other key areas to ensure that our young people are equipped to contribute to the advancement of the development of the country. So we're going to move, speaking about young people, I think we're going to segue very nicely into our presentation from our colleague from Restless Development, who is going to tell us about the First Time Young Mothers program that is being implemented in Simiyu and Dodoma. And so we're going to hear about the experiences that have come out of that program, and it links very nicely so we know about the challenges that our young people face, and particularly those first-time young mothers who are a key target group as we talk about adolescents and young people who are particularly vulnerable. So let's hand over to Restless Development to hear about that program that they've been implementing.
Hello. Yeah, for the sake of those who are not in, before we came in front, my name is Benetus Boniface, and I'm a program coordinator from Research Development. Very briefly, Research Development is a youth-led organization which has been here for more than 30 years. So we have a very good experience of working with young people. And so we mainly work with young people in 4 programmatic areas, one of them being voice and governance. We train young people on how to become leaders of their lives, but again, leaders of their communities. Again, we also work with young people on economic empowerment and education, and we also work with young people on gender and sexual reproductive health and rights. But again, we also work with young people to support them in fighting against climate change issues or effects. And so, yeah, we have been working with young people, as I said, for more than 30 years. So very specifically, because of time, we've been working with UNFPA from 2019 in implementing a program that actually aims at empowering first-time young mothers and adolescents in Dodoma and Simiyu. And we have been training these first-time young mothers on livelihood or economic empowerment, sexual reproductive health and rights. But again, linking them with various opportunities based on their needs. But again, we've been supporting them with, psychosocial support. As you know, first-time young mothers is one of the groups in the community that is really not valued. I think you all are, you can agree with me. When a girl drops out of school just because of pregnancy, you can imagine the value, of this girl that she has in the community. So there are a lot of factors, a lot of, hindrances for this girl to, to progress actually with her life in the community. So again, we've been also working with, the community, trying to change their attitudes when it comes to, how they value these girls in the community, because we have been trying as much as we can to work with the local government authorities in these communities to make sure that, the community is able to, start thinking very positively and supporting these young people, to progress with their lives. And so again, we also support these young people with leadership skills and advocacy skills. We train them to be able to collect data and do what we call data accountability in their communities by raising their voices, participating in various decision-making processes with the data that they collect in the community, so that they're able to influence various decisions in favor of, themselves, but again, the other young people in their communities. So very briefly, that's what we have been doing. So I have a very short video that really, tells most of the things that I have covered and those that I haven't covered. So I invite you to watch this video, and from there, we'll be able to discuss or answer or respond to any question that you might have. Thank you.
Wasichana wengi wenye uzao mmoja walikuwa na ndoto kubwa, lakini wengi wao hujihisi upweke na kuona kwamba ndoto zao zimekufa wanapoanza kulea watoto wao, kwani hutengwa na jamii na kuonekana si chochote si lolote, jambo ambalo sio kweli.
Mimi nilikuwa napenda kusoma kutokana na changamoto za maisha duni hapa nyumbani, kuishi na mzazi mmoja. Mzazi hana ajira na kakangu ana ajira, nikaingiwa kwenye changamoto za tamaa. Kama usafiri ulikuwa shida, dai la kula shule, hicho ndio kilichonipelekea mimi nikaingia katika makundi ambayo sio mazuri, nikapata ujauzito, nikashindwa kuendelea na masomo. Na mtoto mmoja wa kiume ana miaka 6, anasoma darasa la kwanza. Matokeo ya ujauzito yalinifanya kukatiza ndoto zangu, kama vile kucheza mpira wa kikapu na kuimba kwaya, kwa sababu sikuweza tena kwenda shule, maana mazoezi ya mpira nilikuwa napatia shule na kuimba nilikuwa naona aibu hata kwenda kanisani mazoezini kutokana na ujauzito.
Nikiwa mdogo nitamani kuwa mwanajeshi. Nikiwa kidato cha pili pata ujauzito na ndoto zangu zikazima pale pale.
Shirika la Umoja wa Mataifa la idadi ya watu UNFPA kupitia Girls Empowerment Program with a focus to first-time young mothers huwajengea uwezo vijana, hususan wasichana, katika masuala ya makuzi na kufanya maamuzi kuhusu mustakabali wa maisha yao. Na kwa kupitia mradi wa vijana unaotekelezwa na shirika la Restless Development kwa ufadhili wa UNFPA, wasichana wenye uzao mmoja hupatiwa mafunzo ya ujasiriamali, msaada wa kisaikolojia, elimu ya afya ya uzazi na makuzi, ili kuwawezesha kiuchumi na kuwajengea kujiamini na kufanya maamuzi huru yenye tija juu ya maisha yao na miili yao.
Kujikua sio kuanguka. Namshukuru Mwenyezi Mungu, nimekutana na shirika la Restless Development. Wamenipatia mafunzo ya stadi za maisha, afya ya uzazi, ujasiriamali na mafunzo ya ufundi cherehani. Kwangu mimi nashukuru sana, wamenisaidia na nimepiga hatua sehemu kubwa sana, nashukuru.
Fedha anazopata Kabula kupitia biashara yake ya ndizi inamsaidia kujikimu mahitaji yake na mtoto wake, lakini pia amekuwa na uwezo wa kulipia pango. Mafunzo haya ya udereva yanampa fursa ya kujihakikishia uhakika wa kipato na kuongeza wigo wa shughuli ambazo anaweza kuzifanya kwa kuwa na stadi hizi muhimu. Ili kutatua changamoto ya uchumi duni kwa wasichana wenye uzao mmoja na kuhakikisha wana kipato endelevu cha kuwasaidia kuendesha maisha na ya watoto wao bila kuwa tegemezi, wasichana wenye uzao mmoja wameunganishwa kwenye huduma rafiki za afya na kuwawezesha kupata bima za afya kupitia kamati za afya.
Mradi wa Vijana Tunaweza uliweza kutuunganisha na watoa huduma wa afya ambao walitupatia huduma ya afya ya uzazi wa mpango, malezi bora kwa mtoto, jinsi ya kujikinga na magonjwa ya kujamiana, pamoja na kupima afya ya mmoja mmoja.
Shirika la Umoja wa Mataifa la idadi ya watu UNFPA limeboresha vituo vya afya ili kuhakikisha wasichana wenye uzao mmoja wanapata huduma bora na zenye kuzingatia haki, yaani haki ya kuwa na afya bora ya uzazi, haki ya kuwa huru kufanya maamuzi kuhusu mahusiano, haki ya faragha na usiri wakati wa kupatiwa huduma ya afya ya uzazi, haki ya kupata huduma bora ya afya ya uzazi inayokidhi mahitaji yake na anayoweza kumudu, vile vile haki ya kulindwa na kupata msaada wa kisaikolojia, yani psychosocial counseling.
Niliweza mabinti kuwahusisha katika elimu ya afya ya akili, psychosocial counseling. Lakini si hicho tu, pia tulikuwa tunaweza kuwatembelea majumbani. Wameweza kuelewa kwamba kumbe hata huyu binti akizaa akiwa nyumbani bado kuna safari nyingine anaweza akaifanya nzuri ya kimaendeleo. Ambacho naweza kuomba jamii, wazazi kwa ujumla, waonyeshe ushirikiano na wawape support ya mabinti kwa ajili ya kwamba waone kwamba huu mradi umekuja ni kama fursa kwao, kwa sababu wamewakujikwamua kiuchumi, kimaisha na bado hata familia pia na kijamii. Kwa hiyo wachukulie kama ni fursa ili waweze kuwasapoti mradi waweze kuendelea.
Ili kuhakikisha tunakuwa na kizazi cha wasichana viongozi wanaojitambua na kitakachokuwa salama na mimba za utotoni, ukatili wa kijinsia, virusi vya ukimwi na mimba za utotoni, wasichana balehe ni sehemu ya kundi muhimu lenye kuongeza chachu ya mabadiliko na kuwahamasisha mabinti wenzao kwa kukutana na viongozi wa serikali za mtaa na wadau wengine mbalimbali. Wasichana hawa huwasilisha maoni, mapendekezo na kujadiliana juu ya ufumbuzi wa changamoto mbalimbali ili kutengeneza mahusiano rafiki na endelevu.
Baada ya kuchaguliwa kuingia kwenye mradi huu, tulipewa mafunzo ya kuwa kiongozi. Nilishiriki mafunzo katika serikali za mitaa, jinsi wanavyofanya kazi, utoaji taarifa. Nilichukua hatua ya kufanya mambo mbalimbali ikiwemo kuzungumza na watoto wa shule ya msingi Iyumbu siku ya mtoto wa kike duniani, ambapo niligusia uongozi, ukatili wa kijinsia na ndoa za utotoni.
Manufaa ambayo niliyapata kwenye mradi wa Vijana Tunaweza ilinijengea ujasiri. Nilipata fursa ya kuongoza vijana wenzangu na kutatua changamoto ambazo zinatukabili sisi kama vijana kwenye jamii. Sisi kama mabinti tulipata fursa ya kuwakilisha mawazo yetu kwenye kamati ya maendeleo ya kata Nyangokoro. Katika harakati za kujikwamua kiuchumi, tulianzisha kikundi cha mabinti ambacho kinahusika na kujishughulisha na kilimo cha pamba kata ya Nyangokoro. Faida nyingi ambazo tumezipata ni kwamba tumekuwa na ujasiri wa kujiamini kwa kile ambacho tunakihitaji. Pengine kwa mfano kama mimi hapa ningekuwa nahitaji labda pesa kwa ajili ya kitu fulani, za rosheni, mimi kama binti nahitaji nijipodoe, na kuwa nayo mimi kama mimi, siendi kuazima kwa mtu au kuomba kwa mtu. Ndio sababu ambayo inanipelekea mimi najiamini au sipati mimba za utotoni, kwa sababu nakuwa na riski ambayo mimi mwenyewe naweza nikajipatia kuliko kuwa namtegemea mtu. Kwa hiyo inanitoa kwenye ile changamoto ya kwamba nitegemezi.
Kwanza kabisa mimi ni kiongozi wa kikundi ambacho ni cha nguvu ya msichana. Pia kikundi hichi kimesajiliwa na tuna hati ya usajili wa kikundi. Tunajishughulisha na uokaji. Kwanza tulikaa kama kikundi tukapata hilo wazo la biashara, kwa sababu sehemu ambayo tunaishi hakuna bakery. Kwa hiyo tuliwaza sisi kama kikundi, tukatoa wazo letu na tukaona tukifanya hii biashara itatulipa kwa mazingira ambayo tunaishi. Na pia baada ya kutoa wazo letu kwenye mradi, tuliwaambia tuna hilo wazo, wakatupatia mafunzo ya uokaji, mikate, mandazi, keki. Baada ya hapo tulikuwa tayari tukaanza kazi, kwa sababu pia baada ya kupata mafunzo tulipata vifaa pia vya kuanzia. Kwa hiyo tulikuwa na vifaa vya kuanzia na tukaanza kufanya uokaji na tunasambaza pia madukani. Na pia hata tuna vyeti wote vya usindikaji. Wito wangu kwa wazazi, walezi na serikali kwa ujumla, waone huu mradi kama fursa kwetu sisi, kwa sababu una manufaa. Sisi pia umetuletea manufaa makubwa na naweza ngasema tuko vizuri sana kwa sasa hivi.
UNFPA inaunga mkono serikali ya Jamhuri ya Muungano wa Tanzania katika ajenda ya taifa na maendeleo endelevu kwa vijana balehe nchini Tanzania. Ajenda ambayo inatekelezwa katika nguzo 6 ambazo ni maambukizi ya virusi vya ukimwi, mimba za utotoni, kuzuia ukatili wa kimwili, kingono na kisaikolojia, kuimarisha hali ya lishe na kuwajengea ujuzi na uwezo wa wasichana kupata fursa mbalimbali. Serikali za mtaa husaidia katika kuwapata mabinti wenye uzao mmoja wanaoishi katika mazingira magumu kwa kupata mapendekezo kutoka katika jamii. Kisha wanakijiji hukaa pamoja ili kuangalia uhalali wa majina ya wasichana wenye uzao mmoja na kukubaliana kwa pamoja.
Kwanza naomba niwashukuru sana Restless kupitia mradi wa Vijana Tunaweza na UNFPA kama mfadhili. Tunawashukuru kwa kutambua na kwa kuchagua halmashauri ya mji kama ni sehemu ya kufanya pilot ya mradi wa Vijana Tunaweza. Kingine cha msingi zaidi cha kukishukuru ni namna gani mradi wa Vijana Tunaweza umekuwa ni shirikishi, kwa sababu haukuja tu wao wamekuja moja kwa moja, lakini umekuja kwa kufika kwenye viongozi wa mkoa, wilaya na halmashauri. Kwa kimsingi ni mradi mmoja ambao ni shirikishi, na kimsingi tumeshirikishwa kwenye hatua zote, kuanzia hatua ya awali ya uibuaji wa mradi, kwenye capacity building, kwenye ufuatiliaji. Kwa niko nasema kwamba mradi ni shirikishi, inamaanisha kwenye mazingira hayo. Na mradi huu kimsingi umekuwa na tija sana kwa mabinti wenyewe. Ukiangalia mwanzo wa mradi na sasa hivi, mabinti wamekuwa wamebadilika sana, lakini kubwa ni mabadiliko ya kifikra. Kwenye upande wa mafunzo, mradi huu pia umekuwa ukitupa mafunzo, sio tu mabinti, hata sisi viongozi tumeshiriki kwa pamoja na mabinti. Mabinti wametoa maoni yao, wametoa mawazo yao, lakini sisi kama serikali tumechukua mawazo yao. Kubwa kama serikali ambayo tumeifanya ni kuwatambua mabinti kwanza, kwa kuhakikisha vikundi vyao ambavyo wamevianzisha vinasajiliwa, na mpaka tunavyoongea sasa hivi vikundi vya young girls pamoja na first time young mothers vikundi vimeshasajiliwa na wanavyo vyeti vyao vya kutambuliwa. Tuna fursa za mikopo ambazo waliwasilisha wenyewe kwamba wana biashara vidogo vidogo ambavyo wamevianza. Kwa sisi kama serikali tuko tayari kuwashika mkono kupitia miradi yao ambao wameanzisha. Lakini kama serikali tunajali afya. Kwa hiyo tumehakikisha kwa kushirikiana na Restless na mfadhili wa UNFPA kuhakikisha mabinti hao wanaunganishwa kwenye bima za afya. Kwa kiufupi kabisa, napenda kuwashukuru sana Restless, napenda kuwashukuru UNFPA, na sisi tunaombi kwa mradi huu usiishie tu kwenye kata mbili tu za Somanda na kata Nyangokolo. Mradi huu pia tunaomba mapendekezo yaweze kufanyika kwenye halmashauri yetu kwa maana ya kata zote 10, lakini ikiwezekana kama uwezo utakuwa
I think you have all seen the video actually talks almost everything. So just for the sake of time, yeah, I can just end here. Be able to respond to any questions or have any kind of discussion regarding to, what has been presented in the video. Thank you.
Excellent. Thank you very much, Benicius. I think really good work. Unfortunately, because of my angle, I couldn't see as well as you, but I'm sure you saw all the excellent work happening in that First Time Young Mothers program, and I'm sure you have many questions for the panelists. What I'm going to do is I'm going to finish with the panelists so that we have more time for questions and answers, right? But I think it's flown very nicely because we started with the data and the evidence pointing us to the context, the situation in terms of the population growth and young people. We heard about the commitments that the government of Tanzania has made in terms of advancing sexual and reproductive health and rights, and some of the advances that have been made in terms of maternal health and other areas. And then we saw, moving from the level of commitments at national level, how the programs are actually translating on the ground in supporting our adolescents and young people, including our first-time young mothers, in advancing their sexual and reproductive health and rights and their education. So I think it's a nice, seamless transition. So I'm going to move over now to Sahara Sparks and hear from Nectar in terms of how they have been using innovation to advance sexual and reproductive health and rights among young people. So over to you, Nectar.
All right, thank you. Good afternoon, everybody. Okay, my name is Nectar Richard, as stated. I am not Nectar, but I'm Nectar, N-E-C-T-A. I come from Sahara Ventures, or Sahara Sparks, as she mentioned. Sahara Ventures is a group of companies. Sahara Sparks is a part of it as well. And we deal with innovation, technology, and creating solutions that impact young people and Tanzania in general. So under Sahara Sparks, there is AMUA Accelerator. And this accelerator is to accelerate startups or solutions that are presented by youth for the youth. So AMUA is, oh, okay, thank you. I think it's gonna be like a full screen. Right. So AMUA stands for the Accelerated Initiative Modern Technology Universal Access to SRH Adolescents for Adolescents and Youth. So we're aiming to support innovative solutions that youth come up with in the area of SRH. And these solutions can be either targeting different kind of interventions. Can I have the next slide, please? Okay. So how the accelerator works is sort of like this kind of process. We start with a challenge definition. So we collect stakeholders, either the government officials or the youth as well, development organizations. We come together and then we start to define exactly what the challenge is on the ground and what statements that we should have in order for us to call for applications. So on the call of applications is where youth or the target audience sends their applications to us, and then after that we do judging and screening. Basically, we receive the applications and then we select participants or the best ideas to come up for a boot camp. So during the boot camp, we have workshops, and it could take days or even a week or 2 weeks to have this kind of training where we change from idea to having a prototype. So in this kind of boot camp, these people could either create teams, they could either work alone, or they could even come up with new ideas from the ones that they have already submitted. And then afterwards, we move on to acceleration. This one takes 3 months. So in this stage, we move from being an idea stage, from being a prototype to having an MVP, a minimal viable product. And then at the end of the day, during the demo day is when the teams receive funding, and we select the top 3 who are the winners to receive the funding. And as well, the same day is sort of like a marketplace kind of thing where they could showcase what they have created in the past 3 months. So far, AMOA has run 4 interventions. The first one was Innovate for Sexuality, and this one was launched all over Tanzania. We received applications from different regions, and this one had a special focus on teenage pregnancy. And then the next after that was Innovate for People with Disabilities, and it was SRH focused on people with disability, meaning that youth came up with, youth, especially the disabled, came up with solutions that were targeting the PWD group. And then the third one was Innovate for Data. This one we were solving the challenge of data gap between the stakeholders. And then finally, we had a focus on Zanzibar, and it was the first ever innovation accelerator that was launched in the Isles. So this accelerator, we welcomed youth from Zanzibar and Pemba to come together and create their own profiles. On stage here, I was supposed to be accompanied with Tai, but I think she's right over there. I think she's going to tell us more about it in the next video that's going to come up. But Tai has been with us in the first cohort. We've run 4 interventions, and these are the profiles, the top profiles that we have for AMOA Accelerator. So for Tai, they've been working for how long exactly? For Tai, 10 years. Oh yes, they celebrated the 10 years this year. So 10 years for Tai, and they have been able to reach over 33,000 youth, produce 7 comics, produced 33 animation, and have reached 13 regions here in Tanzania. But as well, the second cohort was Maisha Package, and Maisha Package works with young mothers and who support them in terms of capacitating entrepreneurial skills, and as well, they make their own reusable pads, and she buys from the women that she has capacitated. And then so Maisha Package have been able to win the Tony Elumelu Fund. She's been able to pitch for the Clinton Global Initiative Platform. But as well, she has been able to reach 200 young women who have been provided the sanitary pads as well in Manyara. And then our third cohort was Afya Intelligence. So Afya Intelligence started as an SRH, started answering on the SRH component, but now it's a fully fledged healthcare system. They transform healthcare data into predictive analytics, and they work for, they have several clients, 7 of them, namely JSI, Micro Eyes, and others as well. But they've also created a chatbot that offers easy access to guidelines for 500 immunization officers. And I think we have Afya Intelligence today here, if I'm not wrong. Is Afya Intelligence here? No, it's not. Okay, so the other one, who they were very excited about this session as well. They promised to be here, but yeah. And then finally, we have Binti House. So Binti House was last year. Binti House is a platform that provides age-appropriate SRH. Binti House is in Pemba. And they provide SRH knowledge to Vikundi or Vikoba groups, as we know them. And Binti House generates revenue by making adult diapers, baby diapers, sanitary pads, and seaweed soap. So we know that seaweed is a booming business in Zanzibar. So right now we're trying to find opportunities for Binti House to develop her seaweed business in order to run Binti House platform. But so far, she has been able to sell over 500 sanitary pads in Zanzibar. She has been able to host weekly SRH sessions in those Vikundi, groups, but as well, she has been able to visit 5 secondary schools that are in Pemba. She mentioned some couple of regions there in Pemba she has been able to close to. Next slide, please. So in numbers or in total, January, AMUA has been able to have 95,000 reach on social media platforms. We have a listenership, we've been having a listenership of 2 million. And the comic books that are produced by Tai are 7. And finally, the youth that are reached is more than 33,000 here in Tanzania. Next slide, please. So far, this program has been running for 5 years now, AMUA. And as well, we've been having we've of course had some lessons on the way that we have learned. But first was the involvement of stakeholders. It is, in our area of work, we have discovered it is very important to work with stakeholders, namely the government, to be precise, because they're the ones who can either tell us what to expect in the front or let us know if we're going in the right direction and what is to be expected from the youth on ground. And another lesson that we've learned was the rural areas that we work with. We need to have creative efforts. How can we involve these people in rural areas? We need to have creative efforts where the women, the girls, the youth out there can feel involved. So we either have ambassadors or we either create this kind of inclusive programs where we can be understood and where we can actually involve them in the AMUA programs that we have. But finally, the power of storytelling. We see how storytelling is very impactful in terms of girls get to see their stories and get to see how decision making and how they can actually relate to the character that they find on screen. And I think after this slide, we're going to find a short little animation for Kichanga. Yes, so we're going to see animation about teen pregnancy, and it's a bit of a fun kind of thing.
Shikamoo baba. Natamani mizimu ya wazee iyeyushe, nirudi zangu shule nisome. Nimeaibika sana jamani. Mimba za utotoni, oye! Mama! Toto, amka bachi, tumalizaje bichosti? Chi ulitaka mwenyewe? Nisikilize wewe dogo. Mimi? Kwani naongea na nyani? Hivi, naota au kweli nimejifungua? Umenuia maneno. Nakumbuka hakuna kitu kikali kama ulimi wa binadamu. Si unataka mimba ipotee, urudi shule, uepuke aibu mtaani? Ndiyo, sitaki kujifungua nikiwa mtoto. Nataka nisome, niwe nesi. Sitaki kuziharibu ndoto zangu. Ungekuwa unakimbilia vitabu maktaba na sio wanaume na hela zao. Kwa hiyo upotei? Nitapotea tu, usijali. Udhaifu wako kupenda dezo na vitu vizuri ndio umenifanya nije muda huu. Mimi nataka nizaliwe na ngeti PhD, sio form 1 failure. Unacha kujieleza? Zinja alinishawishi, mimi sikutaka. Haya, utajifungua kwa uchungu na utalea kwa mateso. Mbona nigenda, niache sitaki. Niache sitaki. Wewe mtoto niache. Sirudi tena mapenzi utotoni. Siendekezi tamaa na kushawishiwa na wanaume. Naahidi kutafuta maarifa ya afya ya uzazi. Naipenda shule. Nataka kuwa nesi.
Kwa hiyo twende au utafaidi wewe?
Usije ukathubutu kunitafuta wala kunisumbua tena. Ukiendelea miaka 30 itakufuata. Achana naye. Usije ukawa mama mlezi, muda si wako. Twende ukanisuke.
That is Kichanga Animation, produced by Thai Animation Studios. Yeah, so that is a more accelerator, and I think, as my colleague said, I will be expecting questions that may arise from this discussion. Asante.
Thank you very much, Nectar and not Nectar. But no, interesting video, interesting work on innovations, in relation to sexual and reproductive health and rights. Particularly, these are the issues and the kinds of communication that will interest and that speak to our young people. So it's interesting to see some of the messages coming out and some of the work that you have been doing. And as well, one of the key pieces that you mentioned is not only around that education and information, but there's a component that leads to economic empowerment. And we spoke about that earlier in the discussion. So the components of health, education, and economic empowerment for our young people that will allow them to, to effectively be equipped to contribute to the development of the country. Excellent. So we're going to move now to our final presenter from Tama. That's Lucy, who's going to tell us a bit about some work that Tama has been doing in relation to maternal health. Lucy?
Thank you. Now is a time for Nas from Kichanga, the midwife from here. My name is Lucy Mabada from Tanzania Midwife Association. I'm going to present about the UNFPA Maternal Health Program. Next slide, please. My presentation layout is maternal health implementing partners, intervention and the key achievement, and lesson learned, and a human interest story. Next slide, please. The maternal health program is implemented by 5 partners, which is Tanzania Training Center for International Health, that is TTCIH, the Association of Obstetricians and Gynecologists, that is AGOTA, Tanzania Midwife Association, TAMA, Ministry of Health, and the Department of Nursing and Midwifery Services. Our intervention is on emergency obstetric and newborn care, that is EMOC, also midwifery trainings, and the MPDCR, that is maternal perinatal death surveillance, and we are doing revision after the maternal death or perinatal death occur, and also about the fistula. This fistula is mainly occurs for young girls who are having some difficulty during deliveries. And our approach is capacity building of healthcare to healthcare workers, and the policy engagement and the advocacy. And we don't forget about the social and the behavior change communication. And also we are doing the research and the publications. Our key achievement, we have developed a lot of national guidelines and a protocol, like midwifery curriculum. Now we can say we have like a standalone midwifery that is until level 7. We are doing advocacy to strengthening midwifery, as we said, MPDCR and the EMOC. Services provision through, like sometime every year we are celebrating International Days of Midwives. And also we improved quality of care as a result of mentorship in a selected region, like Dodoma, especially the facility which is supported by UNFPA. We are doing strengthening provision of RMNCHA services during emergency for humanitarian or COVID-19. Like during the COVID-19, we managed to develop the mental health and the psychosocial support for health workers guideline because it is a new disease. I think almost all of us, we have panicking during this COVID, so we managed to develop because some of healthcare providers, they are worried, they are panicking. So, and our key achievement, you can say, improve coordination of the RMCHA technical working groups, meeting in collaboration with the Ministry of Health, and they will contribute to delaying second pregnant for the first-time young mother in the program site of Kigoma, Dodoma, and the Simiyu. In the Tama also, we have the first-time young mother in Kigoma we are working on. Our lesson line, we can say, empowering service providers, supervisors, and the facility managers through training is one of the pillars for sustainability of quality care. However, training alone is insufficient, and has to go along with the availability of proper equipment and the human resource for the health. Thank you.
Thank you very much. And I think we've had such a very interesting presentations from all our panelists. And I'm going to go shortly to someone in the audience, and we're going to hear from Gertrude. But before that, we wanted to hear from you in terms of any questions or comments. We've spoken about the what. So the data has told us what the issues are that we're dealing with at country level. So we know where the evidence is taking us. We know what kind of commitments the government has made in relation to advancing sexual and reproductive health and rights. We know what the progress is, but we know that there are still challenges that remain. We know who we're working for, so we've heard a common thread right across the room, and we've talked about our adolescents and young people and the importance of investing in their health, in their education, their well-being, and their empowerment. And we've heard specifically through the programming around first-time young mothers, we've heard about adolescents with disabilities, and so we've heard about the importance of these young people in advancing the country's development. We've heard about the how, so we've heard about innovation and how innovation has been used to advance the work around sexual and reproductive health and rights. And we've heard where we're working, and there's so much work taking place. This is just a tip of the iceberg, but we've heard about the work in Simiyu, in Dodoma, in Zanzibar, in Pemba, and we know there's work taking place right across the country. And so the importance of partnerships is an area that I think we must emphasize, and we've seen clear evidence of that importance in terms of partnerships with UNFPA, the Ministry of Health, and our partners here represented on the platform. So now I'm going to hand over to you to receive any questions or comments that you may have for our panelists. And I see one hand here. Do we have a mic for you? Maybe we'll take a round of about 4, and then we come back to the panel for responses. Thank you.
Sure. Thank you so much. My name is Sam Okoth from Nairobi. I'm a health economist by profession. Interesting video which immediately made me think of a question. That was the video from Thai animation. And this question will go to the UNFP colleague Samuel Msokwa. And maybe it will be a food for thought. Not really, you don't really have to give an answer for this, but let it jog your mind. How is NFPA working with the boy child on matters of reproductive health? Because then that particular girl, I think all this was caused by Zinja, who influenced her to accept this pregnancy. And we tend, most often than not, to look at matters RFP or RMNCH with an angle to the girl child, living alone the boy child. 49% population being male in Tanzania. Age where they're getting most pregnant, 25 to 29. Of course, that was girls, no boys mentioned. Girls only get to their menses once in a month. The boy child is active 24 hours. What are we doing? Have we ever thought? Look at condom distributions, possibly, or family planning methods is always advocated for the girl. Is it a right time right now to start thinking about the boy child in all these discussions? Because possibly you are targeting the wrong audience on matters FP. A food for thought. Question to Dr. Mkwana. In your deliberation, you talked so much about education. And I was wondering, is it formal education when you're talking about an educated girl will possibly not get pregnant? Does this education mean the mainstream formal education, or was it education outside the formal system, as in SBCC? And possibly then, how are you collaborating with nectar, not nectar, on how to, sensitize the boy child on issues of social behavior change communication. For you, I just want to know, this education that you talked about, was it formal education, empowerment, or was it education as in sexual reproductive education outside the normal school system? Thank you so much.
Thank you very much. I'd like to thank the whole panel members for their good presentation and enlightening us on the topic. Well, as we follow the data from evidence to action, I just want to throw this also for food for thought. From the THS that was just concluded last year, we saw a lot of improvements, some improvements like Dr. Makwani rightly said, maternal death is improving, and we saw unmet need decreased from 22 to 21, though it remained high for young people, adolescents still 23. And then we saw also teenage pregnancy decrease from 27 to 22. But at the same time, we also saw the modern contraceptive prevalence rate decreased from 32 to 31. And we saw an increase in the use of traditional methods, more especially in the urban regions. And then we saw regions that had very good increase in modern contraceptive use equally has very high teenage pregnancy rates, higher than the national rate. Like Songwe, for example, we have modern contraceptive prevalence rate of 42.9, whereas teenage pregnancy is 44.9. So as we follow the data from evidence to action, I just want to know, the panel members here, what, from the evidence that I just said, what are the actions we put in place to make sure that we address these issues? As the lady from Sahara rightly said, they are doing age-appropriate sexual reproductive health, but we want to hear from all the other colleagues, including the government, of course, what actions are we going to put in place to address some of these issues that the evidence from the data in the DHS is showing? Thank you.
Thank you very much. This question is to Dr. Makwani. And thank you for all the presentation and a very touchy topic. From data to evidence and action. My question is, or my observation is, the demographic population pyramid of Tanzania has not changed for the past 63 years. And we are students of population dynamics. And most of you have been talking about the figures from the population, the mortalities. But for Tanzania, for 63 years, it has not changed. Why? What is happening? And also for Africa. But for the rest of the world, continent, things have changed. Mothers are not dying as we are dying. So we really need data to give us the evidence for this one. But if you want quality data, you have to do quality research. And I'm asking Dr. Makwani, is there a research agenda for in the area of mother, child, adolescent, and so under the Ministry of Health, a national research agenda? And is that research agenda focused along a primary health care approach? And also, is it linked to universal health coverage? Because if we have the agenda, because we have a lot of information and data from small studies. They are doing a lot of effort, really. But they need to be guided for 63 million people by a national agenda, which is absent. But on the other side, there was this innovation from the ground at Uturo in Mbarara. where for 20 years they were able not to record a maternal mortality. Has it been scaled up? Because in the health sector reform report, it was to be scaled up. Thank you.
Good, thanks. So we're going to take two more, and I'm going to ask us to make the comments or the questions very brief because I'm seeing many hands coming up. So let's take these two on this side, and then we complete, and we come back to our panelists for responses.
Okay, thank you very much for this opportunity. First of all, I would like to congratulate all presenters for the very nice presentation. And it's really, we have read a lot. But my first question goes to the last presenter. I don't know her name. But you are talking about the issue of maternal. And one of the areas that we failed to achieve even during the Millennium Development Goals was maternal. And if you look at the THS report of 2016, and comparing to that of 2010, I don't know if I'm correct, the maternal mortality rate raised up from around 4 something to 50 to 500 something, around that. It was a rise up. So now I would like you to tell us, you being in the area which is very special, midwifery, now what is the problem and what are the challenges that you are facing, that you are failing to focus on the Millennium Development Goals, and now we are in the SDG. And another question goes to Mr. Samuel Msokwa. You presented us about a very nice figures with regard to the previous census, and you talked about the issue of population and the resources. But would you say something about the population density in Tanzania? I wish to hear something like that, because you say something about resources, that resources, we cannot generate new resources, but the population is increasing. So I expect to hear something about the population density. And another question also to Msoko again is about the issue of fertility. Is the one, it's a very important indicator for population. Now, would you share us to the issue of fertility momentum? The issue, like taking example of the Western countries, some of the countries like Portugal or Spain, that they're experiencing now total fertility rate is below the momentum. Now, we are having 4.8, which is above the momentum. Now, can you share us the experience for those countries? What are they experiencing right now? And so that you can tell us something for us that we show that, so that we cannot step up to the fertility below the momentum.
Okay, great, thanks. So let's stop there because there's so many questions, I don't want us to lose them. So I'm gonna start maybe with Samueli and then Dr. Makwane and go to our colleague from Tama. And then moving forward, I'm gonna be harsh, 1 question per person, no more than 1.
Okay. Yeah, thank you for the questions. I think I'll go to 2 questions, which I think were directed to me, and probably in some other questions I'll be able to contribute after respective presenters have responded. The first question was from my colleague, you said from Nairobi, an economist. Yeah, you asked about something having clicked in your mind after you saw issues related to a girl child. So you were asking about, what about a boy child? Yes, thank you. We are not like working segregatively, that we segregate boys. We have quite a good number of programs that are supporting both girls and boys. In my presentation, one area that I talked about was SRH education among young people. Normally, we cover both. And also, for gender-based violence, we cover everyone. For example, the country office has supported the government to establish gender desks, police gender desks, where victims of gender violence are reporting. This covers both. But maybe one challenge, for example, if I speak about this, is about the notion that we have in our communities. Normally, cases that are related especially to men, we tend not to report. That's why one, especially on GBV, would think only women are supported, but not. But also, we have programs about adolescent sexuality education that is for both boys and girls. So we don't segregate. Though emphasis is for girl child because according to statistics, they were a bit left behind. So we want to create an environment where both are able to access the services and the support that we provide. But we don't not like leave alone boys to suffer. That's what I can say. The second, I think, was the last question to be asked by my colleague. Sorry, I didn't hear about your name, so I'll go straight to responding to the question. Okay, thank you. So your question was about the population density of the country. Yeah, we have variations in terms of population density. For example, the population density for the country is around 300 plus. But there are some places that are quite populated or dense. For example, you have, because we were talking about the United Republic of Tanzania, and you have the place called Mjini Magharibi, if you are aware. The population density, I think, is about 3,865. Followed by Dar es Salaam, which is about, I think, 3,862. So you can see the variation. You go to Lindi, I think the population density is below 100. So with such varying population densities, and also I talked about natural resources. I didn't talk about general resources, but natural resources. Like the size of the land that we have is limited. When you talk about water, actually due to environmental degradation is declining, so you need to invest so that you have proper use of these, especially natural resources, and also you create conducive environment for people to access these social services. So the density is varying across the country depending on the place, especially in urban areas. Some places are quite dense, like I talked about Mjini Magharibi and Dar es Salaam in particular. Population density is high, 3,000 plus. The second was about the total fertility. You talked about the momentum on this, that we are at 4.8, and you cited, I think, Portugal, where they are below replacement level. And actually, the ideal replacement level is 2.1. So I a bit talked about the second demographic dividend when I was talking about what do we need to invest in based on the structure of the population that we have in the country. So when you compare the two, one, when you talk about Europe and the rest of the West, actually there was a lot of investment and in terms of human capital. So our colleagues there, they no longer talk about this first level of demographic dividend, because for us, we want to reap from the investment that we're investing in young people. For them, it's about a continuation of the already existing human capital to very late stages for the lives of the humankind that they have, because they keep on producing based on the capital that they have. However, it has to be noted, I think, that there is no like an ideal population size that you can say, okay, this is fit for all. Why? Because there are a lot of challenges. You can balance in this indicator, but you go to another indicator, you find that there is imbalance. For example, in some sort of activities or what labor force or whatever areas in Europe, they need some workers from outside. In some areas, we need experts from outside. So you cannot say this is an ideal population that a country needs, but rather what we talk about is about quality of the population that you have so that it can be competent and productive. But you cannot say, Tanzania, you need to have like a cutoff point. For example, there are a number of international conferences that took place. Yes, I'm winding up, thank you, madam. We have the Rome, the first scientific international conference. You have the Mexico City that came up with some, in 1974, that came up with issues of developing population policies. Some countries like China went to the level of saying you need to have one child. But I think now we understand what is happening. Luckily, most of our countries didn't adopt that sort of like aggressive sort of measure to control. But what we are talking about is give a chance, like what my colleague Mike Wan talked about, that spacing so that a mother and a child will be healthy, and also be able to have skills to participate in the production process. Thank you.
Great, thanks. Dr. Makwane?
Thank you very much. It is true, I echo my colleague from Kenya. Boys and girls, we take them together. And this is very well literated in Nahia. I think we can share with you the document after this session. You'll see how much we have tried to provide the gender-balanced interventions in that document. And we do understand, if you don't engage boys, likely that you fail the girls as well. So we take them together. The other area, education. Was it formal or these other types of catch-up educations? I would say formal. And I can give you an example. One day I attended in one of the clinics. I found two girls, both of them, they were 25. The other girl did not go to school. She was in her 4th pregnancy. The girl who was a teacher, she was in her 1st pregnancy. This tells you the difference between the two. So I would say, if you invest for a formal education, you are likely to delay the onset for the girl, for the lady to get pregnant, because she will be struggling with the career and so forth. And when she catches the pregnancy, it's likely she's in a prime age where she's able to take care of that child than the situation we saw here in the videos. So I would say formal, brother. What is the action we put in place for the teenage pregnancies? I think one of the action that you have heard was announced by the President, Mama Samia Suluhu Hassan, that we need to have a catch-up plan for those girls who fall pregnant while they are in school. I think we as implementers, we need to catch up with what the political stage has set, so that we can assist these girls. I'm also the one who suffered about teenage pregnancy. I supported a girl, and then while she was in Form 2, she was pregnant, and she was expelled from school. I was trying to catch her 2 weeks ago. I wanted her to enroll in one of the vocation training schools, and I sent somebody in the village, deep inside the village. They say, she said, I'm now married. So you can see, she has failed to catch up, and we are trying to catch up, but you see she's entangled in the most difficult situation. We are trying to struggle to assist her. Demographic pyramids has not changed over years. I do agree with that, and it is an area that needs more researches, but it counters sometimes what the sentiment were given by the candidate for PhD behind there. We need to balance these things, and we need to be very careful. And I tried to talk it very early in my presentation. Issues of fertility and so forth, we need to balance with the other experiences from other places, how they struggle with it. So there's no clear-cut answer in that area. We just need to see how best we can explore with our demographic pyramid in terms of to pay back in our societies. Uturo model, we are scaling up. As a government, we are scaling up this Uturo model. Actually, it has been, I would say, we have struggled somehow in various models. And recently, we have decided that the model that is going to be followed is the training should, these community health workers need to be trained in their locality, chosen by local settings, trained within their areas, and they will be motivated with some sort of payback for their services. Because most of the evidence which shows that the community health workers were not supplied. The community health workers, they have a family, but they were not remunerated. And thirdly, there was a fragmentation. So like my colleagues in UNFPA or other organizations, they have their own community health workers. So who pays the piper chooses the tune. The community health worker we want now is a streamlined community health worker that can be used by anybody in the ground, taking all the facets of health to the people. We hope we'll make some strides in that area. I don't want to talk about fertility again because it has been alluded. I would like to finish by saying that we thank our colleagues, especially UNFPA. They've supported the government so much. And we are now in a compendium whereby we are procuring life-saving commodities, which includes family planning, those commodities which are required during pregnancy and after pregnancy. We hope this collaboration shall continue, and we hope that as you maintain these organizations, you will continue working with our donors outside the country, like UK and others, USAID, to make sure these partners, they continue working in their communities and serving the people. But also you create an employment for the young people. I can see you should be young, aren't you? Yes, for the young people as well. Maybe the last question that was posed by Dr. there was about the research agenda. There's a big research agenda. Actually, the milestone I've covered about the reduction of maternal mortality, it was driven by evidence. We achieved these strides not just by trial and error. We were doing some, we were delegating some researches, and evidence from those researches were put into operations. So there's a huge research agenda that we can sit aside and discuss about it and explore some of the opportunities which are available. I submit.
Thank you very much. I think I understand that we have about 10 minutes. I don't know where my coordinator is. So what I'm going to do is take a last round of questions very quickly, and then I will ask all the panelists to give us a final word. But before I take those questions, I'm going to ask Gertrude Clement very quickly. She's the General Secretary of the UNFPA Youth Advisory Panel, and she was supposed to make an intervention for us earlier. So I'm going to ask Gertrude very quickly to speak briefly, and then we take a last set of questions, and then we ask each panelist to give us a final word.
Okay. Good afternoon. My name is Gertrude Clement. I'm the General Secretary of Youth Advisory Panel of UNFPA. I'll be very briefly. UNFPA Youth Advisory Panel is a group of young people who are representing youth from different areas in Tanzania, both mainland and in Zanzibar, and we are 16. What we do, we advise UNFPA on different programs concerning young people, especially on sexual and reproductive health. So we are just living to our communities, and we collect the information that we get on SRHR, because we are coming also from different organizations which dealing with sexual and reproductive health. And at the end of the day, we just represent them to UNFPA, because we usually have our meeting, and to our meeting we do the evaluation of the different things that we have obtained through our communities, and at the end of the year we present to UNFPA. And also during different events, especially Youth Week or Youth Day, we have dialogue that we participate, and we discuss different topics that concerning young people on SRHR. For example, last year during the World AIDS Day, we had the discussion about SRHR concerning the data that shows that there is increase of spread of HIV, especially to women and girls, adolescent girls, and we had a lot of discussion about why there is the increase of spread of HIV to young girls and women in Tanzania. And the information that we get through the dialogue that we participated as Youth Advisory Panel, at the end of the day, we had to represent them to UNFPA. And also we participate to different international and national meetings. For example, this year we had a fellow who attended the Health Summit in South Africa. And also we participated on it was a meeting which was about tracking the development of SRHR as the commitment made by SADC members to work on the SRHR to Southern African countries. So every 2 years, they just track their commitment as they decided that they will work on SRHR up to 2013, every SADC member. So after 2 years, they track the development according to the data that has been recorded, and we also participated and show our view, like we see if there's any development, and if there's no any development, then we have to decide like what should we do. Another 2 years that we're going to track the development to see a lot of improvement. That is just briefly on what as Youth Advisory Panel from UNFPA we are doing. And this is because UNFPA, they believe that nothing for young people without young people, and UNFPA is working to young people. They implement their programs about SRHR is for young people, so they can decide by themselves. If you see there is Mr. Samuel Msokwa, is the use from many years ago. So things have changed now. So that's why we need the representation from the young people who are living currently. Thank you.
Thank you very much, Gertrude. I mean, I couldn't have said it better. I'm glad that you recognize Mr. Samuel and not me, because I identify with your age group. Okay, so we take 2 final questions, 1 question per person, and then we hear from the panel. So I have this gentleman here.
Thank you very much. I hope I won't be labeled among the old ones. Yeah, I have a quick question. One is that I'm not sure whether we are tracking the service delivery across the country in a place where it's 4 times the size of my country. My name is Ambrose Katunje, I come from Uganda. And so when you're flying over most of the areas in Tanzania, they are very empty. So the total fertility rate shouldn't be a problem, but should be what development agenda is there for the young population. We have 42 million people in Uganda. That is not even a quarter of the size of this country. I'll go straight to restless development. Why did you choose Simiyu and Dodoma? And my point is that quite interesting and very proactive interventions tend to end up in just very few places. And then it's difficult entirely to track a lot of changes when you are in 2 regions out of the very many. Thank you very much.
Thank you so much for this opportunity. Congratulations to all the panelists for giving us a very good information about following the data from evidence to action. I just have one quick question. My question will go to Dr. Ahmad Makuani. Thank you so much. We have heard from you that you provide education on family planning. This is very good. So I want to understand also, based on your topic of following the data, that first of all, in family planning, how do you follow the data? And then in line with this question, is that what evidence do we have to lead to action in this kind of sense that, of course, using family planning methods is very good, but we have also heard that there are some of the challenges when you are using those family planning methods. So what evidence now do we have so as to lead us to action to continue using the family planning methods? Thank you so much.
Okay, thank you very much. So we're going to start at the end actually with Lucy, because I think there was a question from the previous round. So we'll ask each panelist to just wrap up, and then we close the discussion. But I'm starting with Lucy from this side, please.
Okay, thank you very much. They ask about the number of maternal deaths is still high, 556 per 1,000 live births. It's true, but for now we have done a lot of interventions. Like now for Tanzania, we're talking about ANC, 8 contact. We moved from the focus antenatal care, now we are doing the 8 contact for pregnant women. As we say, for training, emergency, obstetric, and newborn care, we move together, gynecologists and midwives, to go and train and doing coaching and mentorship to our fellow workers in some of facilities. And the referral system also is now strengthening. And for now also we are talking about a mama for, I think, around the country. And for MPDCR, every death when it occurs, we are going to take as seriously, and the discussion is done, and we give some suggestion what to do. So it's a lot of improvement. For now, I can say the number of new maternal deaths, I think, is coming very soon. I don't think we are still having 556. I think we have now dropped from this number. So very soon we are going to hear about the new number of our maternal death. Thank you.
Okay, I don't have any question, but I think I'm going to wrap up. Either mmenielewa sana or nimeongea faster, so you'll have no questions. But just to close up, thank you for listening to my pitch, but as well, I welcome you all to Sahara Sparks. We're having it 13th to 15th of this October. Karibuni sana. It's going to be at National Museum Posta. Thank you.
Okay. Yeah, thank you. Population is a multidimensional phenomena, and unlike things like economic factors where if you have challenges, you have immediate effects, but most of the issues related to population are intergenerational. That if you don't invest in education today, you won't see the impact immediately. You are counting about 10, 15, or 20 plus. So investment in population, it is very important. And at UNFPA, we say everyone counts, and you are striving to deliver a world where every pregnancy is wanted, every child birth is safe, and every young person's potential is fulfilled. That's why at this point, based on our context, especially in Tanzania, we talk about human capital, that this young people boom that we have will be productive. Thank you.
thank you so much. Again, I also join my colleagues to thank all of you for your participation. But before I say something to appreciate you, let me answer the question that was asked. This was directed to me. It's about why SMU and Dodoma. Actually, the main two reasons for the selection of the locations or regions to operate. One is the early pregnancy rate in the regions, but the other one is the priority regions for organizations. There are so many factors that we always consider, the poverty and other factors in our strategies. So we always have priority areas that we want to operate in a certain period of time. But again, we also have other programs of the same nature in other regions and other donors or funders apart from UNFPA. The program that operates in Dodoma and SMU is funded by UNFPA, but we also have the same program that reaches 90,000 adolescent girls and boys in Mbeya and Songwe, covering all the districts, 12 districts in the two regions, and this has been operating under the support of UNICEF and Global Affairs Canada for 3 years. So we have other interventions in other areas. Now, again, thank you so much for listening. By just concluding, I would rather say there is a lot to be done when it comes to supporting young people in the country. I think the data has really told us that we have a very large percent of young people in the country. And from our experience of working with young people for more than 30 years in Tanzania and across the globe, because we are also affiliated with research development globally, there is a lot to be done in Tanzania. There is a lot of opportunities to support young people in different thematic areas when it comes to life skills, employability skills. There is a lot to be done, and this cannot be achieved without partnership. We really need to strengthen on how we work with each other. There are a lot of partners to be involved when it comes to working with young people. So there is a lot to be done, and I think this is what we should move out of this room with. Every one of us has a role to play when it comes to supporting young people. Thank you.
First of all, I think for the whole questions, the issue here is how do you track family planning? First of all, I should declare that I was born in a family from Yao. And within that tribe, there is a vocabulary for family planning. So usually when I talk about family planning, I try to balance my cultural background against what other people feel. In the 70s, that's when I heard about family planning. I was very young. And my mom was talking with a fellow neighbor saying, you know what? We've been told that now there's tablet. If you take that tablet, you don't get pregnant. In Yao tribe, it is not allowed to take back your baby because you are pregnant, to stop breastfeeding because you are pregnant. They call it, God forbid, we don't want that one. And if it happens, you will be a talk of the village. We will dance there and sing your name that you have messed up with your fertility. So most of women, they will make sure that once they deliver, they enroll into family planning. And that is a cultural background. It might be not the same for other cultures. So what evidence do you have on the safety on UNFPA? First of all, we have global evidence. Global evidence. that they get pre-qualified first. And secondly, if there is a country with a very stringent medicine and devices authority, Tanzania is one of it. Tanzania medical authorities is strong. TMDA is very, very strong in that area. And when they have all those global evidences, then they take the role of making sure the country is safe. So I would say most of the products which come here, there are so many products that we refuse to take them. There are so many products. Vendors, they will come, they knock our doors every day, and we say, no, we are limited to these products. And then, how do you track services? We have a tracking mechanism, which is half paper-based and half is electronic, but we are moving towards a fully electronic database. And we thank again our colleagues like UNFPA and others. They are supporting the government in terms of making sure the system is available. So, Madam, just to reassure you that you don't need I worked in one of the facilities. The only family planning that was allowed in that facility was building ovulation. They say, hey, you want to use contraceptive items. So I do understand the reservation, various reservations based on where we come from, based on the culture, based on the religion, but I think the way to go is to combine the two natural methods and these modern methods. We can make some strides in terms of various things, various expectations the community expects from us. The underlying issue here, we are not saying women in Tanzania should not deliver. No. We are saying maintain the interval for 2 to 3 years so that you can build up your health. You can contribute to the family economy and the national economy, and you can have enough space to make sure your child has been adequately breastfed and taken care of thereafter, so that we have a child who is potential to contribute to the national development. This is the key message for our family planning. And all of us, we are in this room, we should take this message.
I think you summarized it so well. Thank you to all our panelists for the very important and excellent and interesting contributions that they've all made. I think we've had such a rich discussions. I know there were more questions, but I'm sure you'll be able to find the person who you want to ask the question and have a more detailed discussion. But I think so many important issues have come out, and I think people and women, and we talk about investments in family planning, in sexual and reproductive health and rights, because we recognize that it's not about telling people what to do, but allowing them to have access to the information and the services so that they have the right and the choices to determine their family size, the space. that they're effectively equipped to contribute to the development of the country. And so we want to thank all our partners for the work that they're doing in maternal health and innovation, the work that you're doing with first-time young mothers at Restless, the leadership of the Ministry of Health in terms of setting the policy framework and championing those commitments that we've made. Dr. Makwane spoke earlier about the ICPD. And I think at the end of the day, it's about partnerships and how we continue to collaborate and work together to ensure that we're enhance the development of the young people in Tanzania to contribute to the country's development aspirations. Thank you so much, and thank you for the questions and the comments and for being attentive listeners and for all the inputs that you've made. Thank you so much, and have a good evening.
One more time, join me in thanking Melissa and her panel for insightful discussion around health and family planning, using data as evidence to implementation. Thank you so much. I would like for the moderator and the panel for just 1 minute to stay for the group photo. And then, as we do that, a couple of housekeeping announcements. As we speak, some sessions are ongoing. Group photographers, come on, please. We have a wonderful panel there. We want to have memories as well. Bring our photos, bring our cameras and phones. Let's take the photo for the panel. If you wish to stand because you'll be sitting for some time. Anyone who wishes to join should join behind the panel. Let's do it. Karibuni, karibuni. Wakati mna join, napenda mtapoenda kuangalia timetable on page 46, you'll see that who is not in Mikumi.